So we're recording.
Hey Darren, I hope you don't mind I don't use my camera.
Your camera for what?
So you all can see me, because I think there's an icon here you can see me if I press the camera.
Oh, I blocked those so we don't have to see you guys.
Right.
Okay, great.
I noticed your block is out.
Okay.
Hey, I even put on a nice shirt.
All right, so getting started. So the discussion points for today is the rotation schedule of how the schedule is going to work during the Block 2 procedures, a little bit about what problem-based learning is about, and then the objectives and the flow of the cases. So again, there's going to be 3 cases that everyone will do with their students. You'll have the same students for the whole block of time. And the 3 cases are Sam, which is the asthma case, Manny, which is the CHF case, and Frank, which is the DKA case. Mixed in with that, depending on which room you're at, you'll be doing procedures for 30 minutes. So either glucometer or intubation, which will have an EMS person, which will either be a paramedic or a nurse that will come in and help run the intubation station. So for example, if you're in room 1, you'll start with the Sam case for 45 minutes, then go into the Manny case, and then you'll leave the room, go do intubation for a half hour, come back to your room, do the Frank case, and then come back out and do the glucometer. We try to do the glucometer after the Frank case in most of the situations so that they kind of do the case, hear about checking your sugar, and then do the glucometer. And then we try to do intubation after one of the respiratory cases so that that would lead in appropriately to the case. So here's a little bit of the flow, depending on which room you're at. So I don't expect you to read it, but just means that everyone's kind of doing something different. So either Maricel or myself or Jose will tell you how much time you have with each case, like how much time is left. And it's kind of important to stay on schedule because if you go over on one case, then it's kind of, you'll go over on the other, and we only have a certain amount of time for each room to be at the intubation station. We only have so much time for your group to be at the glucometer station, because after you leave, then another group has to come. So it's kind of a tight flow to get all these students through all these procedures and the cases. So problem-based learning, and what that is through peer-to-peer interaction, collaborative thinking can lead to an abundance of knowledge. So the point of this is that the students should be leading their own, basically the case, with a little bit of moderation and direction from the faculty member. But really, if a student has a question, they should be asking each other and trying to come up with an answer before the faculty member is just giving away, what the answer is. The students are free to use resources during the case to assist them. So if they don't know the treatment of asthma or DKA, they can look it up. And really the role of the instructor is to facilitate the learning by supporting, guiding, and monitoring the process. So how would we like the flow of the case to go? So first starting with the HPI. So the student should ask the questions. I'd like the students to ask the mannequin the questions. So it's not that they're talking to you as a facilitator, but they should be talking to the patient, the mannequin, and then you speaking for the mannequin or the patient. And I like for one student to start the whole process off with as much HPI they can do, and then you could take turns from there. But if you start having one person ask a question and the next person, kind of the flow isn't the best. So if one student starts off, maybe give them 10 questions and go to the next person, that could work. Then establish a differential diagnosis just from the history. So, once they think they had enough of the history, what do they think the differential diagnosis could be? And then at some point, they should start asking for vitals. I don't usually turn the monitor on until they ask for the patient to be on the monitor. So if they just ask for vitals, I'll read them the vitals of the case. They should go through the physical exam, obviously listening to the heart, lungs. Those would be the sounds that the patient would have. And then anything that the mannequin can't mimic, you'd have to give them the findings. And then go through the differential again. So did anything change after your physical exam? And then starting with treatment and testing, and then we're going to discuss reevaluation and reassessing the patient throughout the case. And then discussing the management. Discussing the mechanism of different treatments, so how do these treatments work? So this is kind of where the facilitating would go. So why do they pick a certain medication? How does that mechanism work of that medication? And what are they expecting to result from that treatment? And number 8 says reporting the case to the attending. And we'll go through that in a minute. So this is what I'm going to show the students again. They saw this diagram in the block 1 procedure orientation, but they're going to see it again. So before the cases even start, I'm going to meet with the students for about 10 minutes and give them another orientation of the lab, so they probably didn't remember everything from last time. And kind of this graph is a little busy, but what it's kind of saying is at any point they can intervene on the patient. So this is different than just doing in this clinical skills exam where they do the history, then the physical, then they come up with a plan. They should have a primary assessment of the patient, intervene if necessary, go on to the history, intervene if necessary, establish your differential diagnosis, go to your physical exam, intervene when necessary, and constantly reevaluating and reorganizing the differential diagnosis. This is the mnemonic I gave them for establishing their differential diagnosis, and then they'll review that at the orientation session before the cases, but having a broad differential. So I'd like them to consider these in their differential when they're thinking of what's going on with the patient. I also go through with them establishing a problem list. So on the whiteboard, they can put down their differentials and then do this, their problem list. So what's coming up abnormal in the HPI, what's coming abnormal in the social history or past medical, what's abnormal in the physical, what's abnormal in the testing that's done on the patient. So then at the end, they can put all this together and see what the best diagnosis is for this set of problems that they encountered. So the first case is Sam, and these are the objectives for the asthma case. So we like them to understand the mechanism of what asthma is, the triggers of it, what the differential diagnosis for shortness of breath in general is at a young age. So this guy, I think he was in his early 20s or right, 25. So what is the differential for shortness of breath in that age range? What are the mechanisms for the treatment for asthma? We're going to show them how to use the peak flow. We're going to show them the jet neb setup, like what it looks like. They should be applying the nasal cannula to the patient. So some of this stuff seems basic, but to a second-year medical student, they don't know what a nasal cannula, they don't know which way it's supposed to go in the nose. They don't know how the jet neb gets unscrewed. So it's basic stuff, but it's something that they should see before they go in the hospital. On the O2 saturation, we did that at the first case, but these are respiratory cases, so this might be more useful this time. And then smoking cessation in this case. I'm going to switch screens so it's a little easier. Can you guys still see? Noel?
Yep.
Okay.
Yes, yes.
I don't know how to move this thing. Oh, there we go. All right. Okay. So stage 1 of the asthma case is really the history and focus physical, evaluating the vital signs. So why is the heart rate elevated? Why is the respiratory rate elevated? And go through why those are abnormal. Again, the differential diagnosis of shortness of breath. Forms of oxygen administration. So what types of oxygen do we have available and what would be the most appropriate in this case? And then what should we look for of signs for deterioration? So are they using accessory muscles? Are they their skin color is cyanotic? And then going to stage 2, and you'll see some common themes in all these stages in all the cases, but always reevaluate. So they applied oxygen, what happened afterwards, and then maybe what's causing the wheezing. So what is the differential of wheezing in patients? Is it everything just pulmonary causes for wheezing? And then finally starting to treat the asthma. So what's the mechanism of these medications? Again, showing them the jet neb treatment. So the jet neb is in the drawer in the room, so you just have to pull it out or have the students pull it out and show them how to unscrew the top. You pretend to put liquid in it, and then it gets hooked up to either air or oxygen, depending if the patient needs oxygen in addition or if you just go onto air. How we can monitor improvement after treatment. So should they reevaluate the patient by auscultating, asking the patient how they feel afterwards, looking at the vital signs? And also another way is using peak flow to see if the jet neb treatment works. So there's a peak flow in all the rooms. So just so that the student knows how to do it, we like all the students to check their own peak flow. So you give them the peak flow and have them all, obviously take a deep breath in, flow out through the peak flow, and see what their peak flow is. In the book of the case, you'll see what the predicted values are for everyone's age, and then you can see, they can look on the chart and see if they're meeting their predicted or not. I'm only standing here because the microphone's up here. So stage 3. So the vital signs are changing. So the heart rate went up. So why did that happen? So trying to get the students to know, the side effects of the medications they're giving. Again, reassessing the patient. So if the treatment worked, do we give that same treatment again? How often can we give that treatment? So asking them those questions. And then when are steroids indicated? And the big issue we have also is what is the route of the steroids. So a lot of times they don't understand the systemic effects of either an oral dose or IV dose, and they're thinking of just the inhaled steroids. So this is something that we could bring home at our cases, is to understand why a systemic type steroid would be more important in this type of case, and how steroids work, and why would it be useful in this case. So finally, stage 4, they got the steroids, so we're going to reassess the patient. Now, what should we look for? We did all these treatments. What should we look for if they're not improving? What treatments are available if they're not improving and they're getting worse? So is there epinephrine we could use? Magnesium could be used. BiPAP can be used. What would the ABG look like? So does every patient with asthma need a blood gas? So probably not. If they're worsening, then we could use an ABG and see if they're compensating or not. So in the case, you'll see like what the pH or the PO2 or PCO2 should be, if they're compensating versus they're not compensating. And then starting to figure out what caused this to happen in this patient. So he's never had this problem before, so what were the triggers? And now that we know what the triggers are, what could we have asked differently in the history to be able to figure out this sooner, what the problem was? And then finally, can the patient be safely discharged in stage 4? If you remember, the heart rate's still 120, 130. So probably it's not a good idea to send the patient home till the vitals stabilize. Also to observe the patient for a couple hours to make sure they don't have rebounds after the medications wear off. So that's where stage 5 comes in, and what patients might be high risk. So even though he's stable, what if he was intubated in the past for his asthma or in the ICU overnight? Would he be safe to go home, or would it be best to observe him maybe for a couple more hours or overnight? Should he go home with any medication? So that's something the students should try to evaluate. And then definitely smoking cessation we need to bring up. Is very important. Something the asthma action plan is in the case. That's something that we can give to patients to show them, depending on what their peak flow is, what type of treatment they should do on their own before coming to the hospital. And then also the student should explain the disease process to the patient. So this guy's 25, now all of a sudden he might start having issues with his asthma, or maybe it's just exercise-induced. So what type of education do we have to provide to the patient? And once all this is done, so hopefully we're at about 40 minutes of the 45 minutes, it'd be good to do a little bit of debriefing. So what would they do differently if they had this case again? What they learned from the case? And we'll go over a little bit more about what debriefing is at the end of the presentation. So next is the CHF case. So the objectives are, again, the mechanism of CHF, the triggers, what are differential diagnosis of shortness of breath in a 60 or 70-year-old person. How about the oxygen delivery? Would we use oxygen differently in a patient that's breathing through their mouth that's more short of breath? So what other options are available? And one of the two cases of either Sam or Manny, I would talk to the students about what if the patient had COPD as well? Do we give them as much oxygen as necessary, or is there, do we use lower doses of oxygen because of their hypoxic drive? So at some point talking about the hypoxic drive I think is important in one of the two respiratory cases. We want the students to apply the EKG leads, and we'll go over that in a minute. So if they ask for an EKG, we want them to put the sticker, actually this shouldn't say EKG lead, this should just say the EKG stickers. So we have the stickers and we have the landmarks, and you can palpate the ribs on our mannequins, so they should put them in the proper position. And then the application of the cardiac monitor. So we have cardiac monitor leads in all the rooms, and I'll show you the landmarks of that. In this case, they should be interpreting the EKG in interpreting the chest x-ray, and discussion of BiPAP, more in this case than the asthma case. So again, stage 1 is basically the same as the SAM case. We're going to do the history physical, evaluate the vital signs, talk about the differential, give oxygen, and what should we be looking for while we're examining this patient for signs of deterioration. Stage 2, reevaluate. So we gave oxygen. What should happen? And he didn't improve that much. So what exam should be ordered to try to get to the bottom of what's going on? And the blood pressure, they're going to be staring at the red beeping in the background of the blood pressure being high. They're going to be talking about beta blockers, calcium channel blockers, ACE inhibitors. So kind of seeing which student would recommend which medication and why. So in this case, probably the first line could maybe Lasix, since we think he's volume overloaded. The physical exam shows edema, JVD. So that might be the first line for his blood pressure. And then reviewing the chest x-ray and EKG in this stage so they know where to go with the rest of the case. Stage 3 would again be reevaluating the patient after whatever blood pressure medicine they gave. We should review the lab results with the patient. What are the role of nitrates? So should this patient get nitrates? So even though they might have diuresed some with the Lasix, his blood pressure is still high. So what if they did want nitrates or a vasodilator? What's the route? So they might not know the nitrates are given sublingual, orally, transdermal, IV. When would each type be indicated? How do we know if the patient's improving or not? That goes along with signs for deterioration. And what additional treatments are available if they're not responding? So can we give nitroglycerin IV? What other medications can we give? BiPAP, they'll talk about intubating the patient, but maybe that's a good point to say what are some of the complications of intubation and what can we do before we intubate the patient. And lastly, stage 4, he's improving, and we want the students to identify the S3 sound. So always ask them to reevaluate the heart, reevaluate the lungs. And so if they reevaluate the heart rate's a lot slower now. Before he was tachycardic, so it's very difficult to hear the S3, but now his heart rate's in the 80s, I believe, 70s, 80s, and you can hear the S3 quite nicely. And then going through the triggers. So in each case, I'd like them to know what type of triggers would cause someone to go into heart failure. Could it be valvular? Could it be an MI? Diet changes, noncompliance with medications. And then should this patient be admitted or discharged? Usually in these cases, I pretend I'm the patient and I say, I really want to go home, doctor, can I go home? You know what's wrong with me? Just change my medicine. But really this patient should be admitted and they should call the admitting doctor. So pretending to call and summarize the case. So at the beginning of the cases, I usually tell them we're going to have someone in the group speak to either the admitting doctor, the primary doctor, and have to summarize what's going on in the case. And this would be a good opportunity, to have someone in the group summarize that. And lastly, debriefing in the last 5 minutes of the case. The DKA case, so the same kind of objectives. The only really difference is the discussion of what is anion gap, how are ketones formed, and a little bit about ABG and DBG interpretations. So this one has the most stages. So again, stage 1 is pretty much the same, except this patient's hypotensive. So what are the causes of hypotension? So could this have been hypovolemic? Could this be sepsis? What are some of the causes of his hypotension? He will not have any peripheral pulses because his blood pressure is so low. So when they do an exam, you can say, well, how were his pulses? And they would have to identify that there were no pulses. And why is that the case? Why is this patient tachypnic? Is it because he's in pain? It says in the case about metabolic causes, but I wouldn't prompt them for that. This case is more designed for them to go down the route of abdominal pain and the differential of abdominal pain versus figuring out that's a metabolic cause in stage 1. So I'm okay with them thinking about this is appendicitis or gastroenteritis for the whole case until we get the lab values back. So stage 2, we got our history. So how do we treat hypotension? How much fluid should we give? This is a young, healthy guy. Is there any concerns about giving him too much fluid? Start ordering lab tests. Usually they'll ask for a CAT scan of his abdomen. So I make up some reason. Either the tech's not available, if the patient's too unstable, but for some way to not do a CAT scan this early on. Stage 3. So we review the lab tests, but only the ones that the students ordered. So in this case, there's more labs that they could have ordered, like ketones, urine, the ABG. So we'll only discuss in this stage what the students actually ordered. I'm sure they'll order a metabolic panel, and we're going to discuss what the anion gap is. So they should have had some of this. Some of this goes in their renal course, which they haven't had yet. But so I'm not sure how much of this, are you familiar? Okay. How much they've had on the anion gap, so this might need a little bit more coaching than other things. Okay. So I was asking Dr. Eisenberg if this was covered, and this is covered somewhat. So what are the differential of a high anion gap acidosis, so the mud piles mnemonic? What are the roles of IV fluids in lowering the serum sugar? And why are we using insulin? So insulin is really not just to lower the sugar, but stopping the ketone formation. And the case, in the description of the case, goes through a lot more about the mechanism, but having the students try to talk through why they're using this. And it's not really supposed to be a lecture. It's supposed to be trying to pull the information out of them. So they've had these lectures. It's somewhere in their head. They were just tested on this during this week. So if we can try to pull the information out, I think it helps with the retention. So if they, instead of us just telling them the information, if we're able to pull it out and they can put everything together, I think that'll help them retain it better. So stage 4, we started the fluids, we started the insulin. So let's reassess the patient. An understanding of what could have triggered this in this patient. Is this because he has an infection that triggered it? Is it because he's stressed? What might the triggers be for someone that has new onset diabetes? And what do we need to be cautious of? He's on an insulin drip, so what might eventually happen? He might become hypoglycemic. Too much fluid, more in pediatrics, but can get cerebral edema. Importance of rechecking the sugar. So again, to avoid hypoglycemia. Why do we need to recheck electrolytes? So at the beginning, when you're discussing the labs in stage 3, the potassium was very high. So a discussion about why the potassium is so high in this case, and what's going to happen to the potassium when patients are given insulin. So we need to recheck those electrolytes. And then how should we monitor the progression of the acidosis? So at the beginning, it would be okay to do an ABG in the earlier stages to see what the respiratory causes are. But maybe later on, maybe a venous blood gas, so it's not as painful, it's easier to obtain, and we can still check the pH between the ABG and BBG, but we're not getting the oxygen component with the BBG. Stage 5, we can review the repeat lab. So what has changed in the labs from stage 3 to stage 5, and why did that happen? So why is the sugar going down? So that one's easier. But what about the anion gap? So why is that closing? The glucose is now lowered. Do we continue insulin? So he still has an anion gap, so we really should continue the insulin. But how do we prevent him from being hypoglycemic? And we'll have to start dextrose to try to balance that out. And does the patient need to be admitted? So every case, they should understand the rationale for the admission. And lastly, stage 6 is pretty much the preparation of the admission. So what do we have to do while he's in the hospital? Diabetic education, diet, converting the insulin drip to longer-acting medicines. And again, they should call the physician and discuss, why they're admitting the patient and so forth.
I know that we want to incorporate, of course, this would be a great step to incorporate that. Why weren't you taking it, right?
Well, in this case, he's new onset diabetic. So all of our patients really have been compliant, even the CHF ones, but you could have a discussion. So he's a new diabetic. Is he going to want to take insulin? How is he going to afford the insulin? And so forth. So that is a good point. So this is a younger guy, and he might not want to give himself shots, but the importance of doing that. So I'm not sure if you guys could hear, but another point was that they had a case on diabetes and someone that was homeless in one of their other courses. So that might be brought up by some of the students. And also explaining what diabetes is to the patient. So this is a younger guy. Now he's scared. What's going to happen to him? What are the risks for the rest of his life having diabetes? So what is debriefing? So debriefing is finding out how the students felt, like how did they think he did in the case? What happened to the patient? So what, did he do well? What did they learn from the case? How does this relate to what they're learning in their classes? what if something was different? So this is what if he didn't improve? If you didn't cover that already, what if he got worse? What if he, what if a certain situation, he didn't have insurance and he couldn't afford the medicine? So this is where you could discuss some of those what ifs. And then what next, what would they do differently if they redid the case again? So this is a couple things. You don't have to cover all these debriefings, but I think a couple of these points to see, what the students took away from the case and what they would have done differently in the past, or in the future, sorry. So for those of you that haven't worked with the mannequins before, this is a screen that basically you'll see when you go into the rooms and turn on, and the computer will be already on and set up for you. The vitals are displayed on the left, but they're also displayed on an additional monitor that the students can see. And then if you click on the patient's name, which is up here called Sam, it will tell you what stage of the case you're currently on, which is stage 1. If you click on that button, this will come up, and these are your options. So as you progress through the different stages, all you would do is click the next stage. All the vital sign changes, the different sounds that the students are to hear have already been pre-programmed. So as soon as you click on the next state, the mannequin will change the parameters, and you just continue on to your discussion and facilitation at the next stage. To go to the next case, you would push stop, and it'd bring you back to the home page where you'd pick the name of the patient of the next case. The laboratory value. So this is on the bottom of the screen. When you hover, when you bring the mouse towards the bottom of the screen, these things will come up, and Jose will have them pre-programmed for you. So there'll be 3 main folders. One's called Sam, one will be called obviously Frank, and one Manny. And you can see here that it says that there's 6 documents in that folder. So when you clicked on it, this will be what comes up. So usually we have like the EKG or something first, and then all the images will be on the either left or the right, and you would just click or push the down button to go from image to image. The real main one that this really affects is the Frank case, because they might not order certain lab tests, so you have to click on which lab you're going to show them. But for the other one, Sam that has an EKG and chest X-ray, I didn't cover this, but depending on how the time goes, it's going to be usually one of your first cases, and you might need more time to get through the case. So if you don't cover an EKG or chest X-ray, I'm okay with that in the SAM case, as long as it's covered at one point during their stay with us. So at some point in the day, they should cover an EKG and chest X-ray. Whether it's done in SAM or not, it's available if you have time to do that. So I want to play a quick video of one of our cases that we've done in the past.
Our patient's still not out of the woods. What do you do?
Lower his heart rate.
He says lower his heart rate. What do you say?
Maybe we can get on.
Insulin. Yeah. We gotta bring this guy's sugar down. That's part of the problem. If you don't correct the underlying problem, you're not gonna make this guy better. So, can I just give him insulin and not think about it? Just say, Nurse, can you grab me some insulin? And
We need 2 insulins.
you need 2 insulin. What do you mean? What do I need to know? Let's think about it. Let's start to think. What does insulin do with the body? Does it cause any shifts of any sort?
All right, so this is an example of, thank you, Dr. Johnson, of how we can facilitate the group. So it's not just telling them what to do, but, what do we have to do? Get a couple opinions from some of the students. How does the insulin work? What is it going to do? So these are a way that you can facilitate the group. Another video.
Right? You feel the tachycardic? How about down here distally? Did you guys?
I didn't feel like I know about
You
it.
couldn't feel one, right? I don't think I felt one either. Well, maybe we'll figure out why that is. Let's take a look at this vitals behind you, right behind you. So tell me what's going on with this heart rate.
It is very tachycardic.
It's tachycardic. What's normal?
Between 100 and 60.
Between 60 and 100.
60 and 100.
Correct. So 100 over 100 is tachycardic. Is that a sinus tachycardia, an atrial tachycardia, or ventricular tachycardia?
And she's science.
It is sinus. How do you know that?
There's a
All right. So again, an opportunity to see how we can do the facilitation by asking them questions and having them actively learning. We'll see some students leaning up against the wall, not participating. So this is a great example of how to get all the 4 students involved in the case. So going on to the procedures part, so intubation. Again, we'll have the intubation in a separate area, in a separate room. And what will happen is there'll be an EMS personnel that will kind of go through these objectives, so the indications, pre-procedure, the differences between a MAC and a Miller blade, how to confirm it, the intubation, and then complications. So this you will not have to worry about. The other person, the EMS personnel, will do that. And then we have an extra room set up for intubation. So if there's 4 students in your group, what I'd like to happen is 2 of them stay with the EMS person and 2 you take into the other room so they have time to practice. So again, there's only 30 minutes for intubation. This talking part takes about 10 minutes to 15 minutes. So I'd like them to have 10 or 15 minutes to practice before they have to go back to the room. So if you could take a couple of the students, and we'll tell you that when you come on the day and show you where that is. The EKGs, so again on the left would be the cardiac monitor lead. So if they ask to put the patient on the monitor, asking them how that's done. So it's not just saying it and then in the hospital, yeah, it magically gets done, but what if there's no nurse in the room? So they should have an idea of how to do that. So my mnemonic is white on the right, and then smoke over fire. So white's on the right, black is on the top left, and then red's on the bottom left. And then I think all the rooms have the 5 leads. If they only had 3, those would be the 3, but then the 4th and 5th are the brown, which goes in the middle. And I have a mnemonic for that, but you could probably figure that out. And then green, I say the opposite of red for Christmas, so it's green and red on the bottom. On the right is your lead for the EKG, so I'd like them to put the stickers on, so you'll see the stickers in the room, and they should feel the landmarks again, put the stickers down when they're requesting the EKG. This will be the glucometer station, and you'll be running the glucometer station. So on the table, you'll see the needles. They have a safety component, so they're going to have to twist off the blue cap that's on them. So it's important to tell them not to just pull it off. If they pull it off, it's spring-loaded, the needle. So if they just pull it, it's going to break the device, the lancet. So they have to turn the blue thing off till it comes off, and then it's ready to be used. They have gauze on the table, alcohol, and Band-Aid. And they're going to be doing this on each other. So if your group has 5 people, it's important to go in a circular format so that one person's doing on the next and they're going to take turns doing it, or else you're going to be stuck having to volunteer your finger for them to check your sugar. So I usually recommend that one seats the doctor, one seats the student, and then they'll all get up after each time and rotate around till everyone has done the procedure. There's a sharp container there, so it's a very basic skill, but kind of we want to focus on a couple things. One is that all the students should wash their hands before they come to do this procedure. So before you leave the mannequin room, have them all wash their hands. There's extra sinks by the bathroom that we get to facilitate so it's not taking a long time for them to wash their hands. They should be wearing gloves during the procedure. And then talking a little bit about like milking the finger so that there's blood at the distal aspect of the finger. Which of the part of the finger is the best spot to check the sugar, so there's less nerve fibers on the edges of the finger, so that's where they should stick. A lot of times they're not holding the lancet up tightly to the skin, and they end up scratching the student, so telling them to place the lancet and hold some pressure against the skin before they push the trigger on it. And then also going through the actual glucometer device. So how does that work? So the number, the test code, and these types. Newer ones don't have the test code, but on these, they have to match the test code to what's programmed into the device. And when you come early on the first day you're here, we can show you the devices and give you a little bit more of training before you start, but it's very basic. They have to put the test strip all the way in. If they don't push the test strip all the way in, it doesn't acknowledge the test strip. And remember, the test strip, the blood has to go on the very tip of the test strip. If you put it on top of the test strip, it doesn't do anything. So that's another common problem the students encounter. So reminding them that they just hold up the end of the tip to the blood, and it will suck the blood into the test strip. when they're done, they should wipe down everything. So you'll see by the sharps container there's a cleaning pad thing, and you'll wipe down the machine and wipe down the table. Usually blood doesn't get everywhere, but we just like to be sure and make sure that everything's wiped off before the next student goes. And that is it. If anyone has any questions. Are you still with us, Noel?
Yeah, I'm still here.
Any?
Yes.
I'm
Yeah.
here. So if on that Monday, the first, that would be the 28th. Actually, we should be there probably around 8 o'clock or so to go through some of this with you, or 8:30. What's your preference?
So the cases start at 9 o'clock, but the orientation for the students will start at 8:45. So yeah, so if you came on your first day coming, for anyone that's their first time, I would come between 8:15 and 8:30, so we could do a quick tutorial on your first go around.
That'd be great. Well, thank you for putting in all this work. That's a lot of work, I tell you. And I've copied some of your slides, so I'll have them in front of me.
I emailed the slides out as well, so you should have them to review the slides, also the cases. If you have any questions before this comes up, then please email me. The reason why we do this orientation is try to standardize the experience that the students get. So sometimes some of the feedback is that the students get a different outcome when they have one faculty versus another, which I understand there's going to be some differences, but the point of this is to try to standardize what the objectives are and how we facilitate the students so that they're not getting a lecture while they're here. It's important for us. This is a hands-on time for them. We'd like them to reevaluate, reassess the patient, be touching the mannequin, and they really don't have a lot of this time of the simulation time, so we want to make the most of it and make sure that's really simulation and not lecture.
Yeah.
All right. So that's pretty much everything. If you have any questions, and again, please email me. Thank you.
Thanks, Aaron.
Thank you. Thank you very much.